I will kick us off today, and we are going to be very pragmatic and practical. There will be no boring theory or other things that we introduce during this educational session. And we, as the UNMC Clerkship directors, wanted to talk a little bit about these orange cards. Some of you have been around for a while and are very familiar with them. We hope to maybe just fill in some gaps or updates, and for the newer faculty, give some explanation as to what these things are. So our orange cards are our clinical evaluations for our students. The language on them comes from UNMC and is core to both all third-year rotations and even some fourth-year rotations. And they come on these orange cards long before Dr. Gallahan and I started in this medical education role. Actually, for several clerkship directors, they've been here. And the goal that we have, the ultimate goal, is to make sure we leverage this summative evaluation for formative feedback so that our students can get some face-to-face interaction and use this as a growth opportunity as much as a grading opportunity. It also practically for us allows us to get these back a little bit more quickly and allows us to meet some of the LCME requirements for turning around grades. While we give this presentation, we are more than happy to field questions in the chat also. We hope to make this as much more of a discussion than a presentation. So please let us know if there are questions or things that you wonder about these orange cards as we go through, and we will try to answer them, or we will answer them in the post information. So the next piece is really important to understand the clinical evaluations. Our clerkship really has three components for grading. 50% of the grade is based on the clinical evaluations or the orange cards. The students get one from each week, and then we average those over the course of the clerkship. They also perform an OSCE, which counts for about 20% of their grade, and they take the shelf, which is another 25%. And I'm talking about this because it's somewhat specific and necessary. What we have seen in the last 18 to 24 months, Dr. Gallahan, correct me if I'm wrong, is some of our clinical evaluation grades have skewed upwards, and there's been a lack of differentiation between students on the clinical evaluations. And we've heard from our house staff as we've gone around over the last month that some of them want to make sure they don't negatively impact someone's grade by giving them an average evaluation rather than an above average evaluation on the orange cards. And ultimately, while the intention is not to harm someone's grade, it will handicap a student that is better in the clinical arena, but less strong on a subject exam, a shelf exam, while it will help the student who is performing poorly in the clinical environment or average in the clinical environment, but a great shelf taker. So the end game of this is that if we don't have variation on these clinical evaluations, we are left with a shelf exam to determine someone's grade, which I know is what most people want to avoid when we have these multiple modes of evaluation. Our OSCE, unfortunately, is not great at differentiating on a larger spectrum. The differences are relatively small. And since it's a small portion of the grade, it is much more difficult to sort students with that assessment method. So with that background, I'm going to turn over to Dr. Gallahan for a little bit, and we'll talk more about the exact components of the orange card.
Yeah, thanks for that introduction, Jason. And I just echo what Jason said at the beginning, that we're hoping this is a little bit more of a conversation rather than just us presenting to the group today. So as Dr. Burrows and I are passing the baton back and forth during this presentation, the person not presenting will be monitoring the chat. So please type in your chat questions and we'll try to address those on the fly or bring them up for actual discussion as we're going through the presentation here. I'd echo a lot of what Jason just mentioned, in that the clinical evaluations are a key, maybe the foundational component, one would say, of our grading scheme. And they play a really important role for the students in a number of ways. Dr. Burrows will go through some of the individual components on the card, and we'll actually bring that up. But a couple things I would point out and just reemphasize is, as Jason mentioned, this is a standardized evaluation across all of the clerkships. So the language on these cards is not something that we came up with. This was devised by the College of Medicine, and the language is the same for the other clerkships. The method that they use to collect this is a little bit different from clerkship to clerkship. In some of the clerkships, some of the departments, they will fill this out in an electronic form, but as Jason mentioned, our hope is that by doing this in a physical form, that we're prompting a little bit more of that face-to-face feedback for the students as they get this evaluation filled out. As we think about the components of the actual card, it's intended to provide the students with actionable feedback about how they're doing in the clinical realm. And so those components, as Dr. Burrows goes through them, I would say think about those as a nice source of things that you can discuss with the students. So it's not meant to just be a, fill the card out, complete the evaluation. It's meant to hopefully prompt conversation as well. And those anchors are there to really help you have some actionable things to give back to the student. One of the other things that we'll talk a little bit about is the narrative comments at the end. And I just want to spend 1 second talking about those to say that those are incredibly important for us. And I think they sometimes get forgotten. I certainly was guilty of that myself as I first transitioned into the faculty role. But as we've had an opportunity to be involved in the clerkship for a few years and seen where those comments go and what they do, I have come to appreciate that they play a super important role, both for getting the students some specific feedback, prompting reflection for them, but then also practically speaking, those comments are used to complete their grades so that those narrative comments, we directly take quotes from the comments that you put on those cards and put those into the narrative summary that the students get at the end of the clerkship. And the next step is many of those comments actually go directly into the MSPE, the dean's letter that the students have that goes out with their residency applications. And so those comments are really important for the students. And I would say becoming even more important as some of the other components that residency programs use to differentiate students go away or transition to formats that make it more difficult to sort through students and figure out who to interview and who to accept into their programs as well. So we'll talk about some of these components in a little bit more detail here, and I'll hand it back over to Jason to actually go through the card, but just to set the stage a little bit in terms of the importance of these, not only for grading, but also for performance improvement and helping our students match into the residency programs that they want to match into down the road too.
And Nate, we had 2 comments in the chat. One, that students self-select faculty who will give above average ratings, and we are not unaware of the fact that students know that there's some gamesmanship to this to help their grade. We are more than happy for evaluations if it's possible to come from 2 people, meaning if it's the end of an inpatient week that the supervising resident and the faculty could work together, even if that's just a brief 30 or 60 seconds where one of the 2 is there and then has to go on to other work. I also think there is a very legitimate concern about not having enough time with the students to adequately assess them, but I'm going to hopefully help with that a little bit as we discuss these orange cards. And Dr. Mock also had the same thing about when they're only there with a week and asking a question, do we need to think about the structure of the rotation? So we can come back to that one, Dr. Mock. So the orange cards have, as I think about them, 3 components. There's the citizenship part at the top, which I view more as professionalism. And for 99+% of our students, this should all be yes, 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 yes. Just know that this is a place where if you have no time other than to circle one of these, that we will take a no on this as a evidence of unprofessionalism. And even if you don't reach out to us, we will reach out to you to try to get some details so that we can then meet with the student. To take a step back from what everyone's thinking we're going to talk about, this professionalism stuff is pretty important, maybe the most important part of the entire card. And what is most helpful to Dr. Gallahan and I is if you can even just send a 1-sentence email that there was some unprofessional behavior. We will do whatever we need to talk to you, whether that's by phone, email, whatever works, make it as brief as possible, and then we will run with it. This unfortunately happens already a couple times a year without us even prompting you guys to give us this feedback. And it's really important for us to know in real time, because if a student's having minor or moderate unprofessionalism issues, nothing egregious, and we're not able to give them feedback, if they repeat those behaviors during the clerkship, at the end, it's very hard for us to give them a failing grade without having given them feedback at some point. So if we find out about these on the last day, our hands are somewhat tied, even if it was repetitive, because the student could say, well, no one talked to me about that. I didn't know I needed to change that behavior. And that's enough for us to not really have a leg to stand on. Now, if it's an egregious, unprofessional episode, that doesn't count any longer. And Dr. Harper asked what defined unprofessional, what counts as a minor problem. So, I think someone who's late to clinic and doesn't necessarily have a reason why they were late, they show up 15-20 minutes late every day, especially if it happens more than once. I think that would be more of a minor thing. That would be something we can correct. Egregious would be, yelling at a patient family or a staff member. And they're very hard to define, but we do have some standardized forms that we can use from UNMC to help guide those conversations. And Dr. Gallahan and I will take it over and do everything beyond just needing to collect the information from you guys. We can come back to discuss this more if we need to. The main parts of these cards that people pay attention to are what I would call the summative domains. And so there's 4 of them. There's clinical reason, patient presentation, one about improvement or responsiveness to feedback, and working or coachability and working relationships. What I want to help for both Lauren and Dr. Mock's comments is first say you do not have to fill all 4 of these out. So if you did not spend enough time to say, I don't know if I can really answer the working relationships or coachability or any of these, you didn't have them present patients formally, you can check not observed. That does not harm the student in any way. If you only fill out one part of this card because that's all you feel like you can accurately describe, that's fine. That's why we're getting these over every week, so that we can hopefully get a breadth of the students' clinical skills and experience. We would ask you guys on these to try to use the anchors as much as possible. They're not perfect. And so sometimes you have to decide, okay, the middle of the rung is average, the one above that's above average, and the highest one is the excellent student. But in the event where you can really tie their behaviors to one of the anchors, we would ask that you use those anchors. And in many ways that shifts it down. And I will tell students all the time, there are some on here about integrating complex patient problems, data, and other things that I don't do the highest score on necessarily with every single patient or every single shift. And so some of them are very high and difficult to achieve as a third-year medical student, and we don't need them to all get perfect scores on these domains. And then the last part of this is obviously the comments and the feedback, which is the most important part for the students and their growth. We, as Dr. Gallahan said, use this for multiple aspects, including their dean's letter when they move forward to the next step. To me, this is the area to have some discussion. If you can bring it back to any of the anchors that you filled out, that's helpful. Many of them are interested in moving up those anchors, obviously, for grading purposes. One easy one to give as an example would be if on coachability, you give them, they have good insight, beginning to set personal goals, and actively seeks feedback. The difference between that in develop personal goals might be to tell them, hey, why don't for next week you develop some personal goals? That allows them to look at that anchor and set maybe more developed and more longitudinal personal goals and move up in that anchor in the next time you evaluate them or for the next evaluator. And there's others in here that you guys can see as you work through the orange cards with the students. Nate, I will pass it back to you. Nate and I were both on call last night, so if neither one of us makes sense, it's okay, just tell Kari.
Well, hopefully we're not talking too much gibberish as we're going through this 15 minutes. But I guess I would back up and say thank you to all of you in that the role that you play is incredibly important for student development. We hope that this orange card is a tool to help you and not something that's a burden on you. And so hopefully we've demystified a little bit of what the orange card is as we've talked this morning. I would say that we can only talk so much about this in a 15-minute session, but if anyone or any group or division has questions or wants to get a little bit more granular with this, or has had problems with the cards and how they work practically for you in your clinical setting, Dr. Burrows and I are more than happy to come and talk with you virtually or in person. That could be a division meeting, that could be one-on-one, but just let us know if you have any questions about this after the presentation. We promised to get back to Terry's comments about the fact that it can be difficult to evaluate students when you have a fairly short time with them. I would emphasize a couple of the things that Dr. Burrows mentioned, one of which is that in my mind, evaluation is a bit of a team sport when we're working in a team environment. And so taking advantage of the other folks that are also working with the student can be very helpful. So if there's a resident there, as Dr. Burrows mentioned, just a brief conversation with them can be really helpful to get some insight into the things that you may not see on the faculty side. If you have advanced practice providers as well, and they're working with the students, they're a great resource and often have a lot of really good context for the well-performing student versus the student that's more on the average side. The last thing I would say on that, and we've talked about this in some of our other faculty development sessions, is learner self-assessment can be very helpful for these conversations and the assessment piece as well. So asking the students, how do you think you did? What are the things that you have identified for yourself as areas for improvement? Those questions can really prompt not only a little bit of additional reflection by the student, but also give you some insight into the things that maybe do need to be addressed with them when you're doing these evaluations and giving them feedback. So that's something that I personally do a lot, pretty much every time I sit down for an evaluation. And would suggest takes a little bit of the burden and the pressure off when you're doing that face-to-face feedback as well. I see a few comments coming in. I don't know if you're monitoring those as we're going through, Jason. I can't keep up.
Dr. Mock basically had just posted the same thing you had said about asking the student to self-assess before giving your assessment. And Dr. Stuhlman thought it was helpful to know that this is a standard format card, but did bring up the fact that it can be a struggle to combine both feedback and evaluation in one card, since summative and formative things sometimes are separate.
Absolutely. Well, I think we will probably stop it there just for time's sake this morning. But again, our offer is out. If anyone has questions offline, please reach out to us. We are happy to help you, help us with this. And know that we are also giving similar presentations for the residents as well, as Jason mentioned. So we're hoping to shift the paradigm just a little bit so that this does become a little bit more of a differentiator for those students who are really strong performers for us. So I appreciate your help in this, and we're here to help you as well.